So carrying on our series about aortic dissections, we talked about the anatomy of the blood vessel, the three layers of the blood vessel. And when an aortic dissection occurs, one of those layers separates off from the other layer, and it can cause problems with blood flow issues to the vital organs. And it can tear open and people exsanguinate from that event. Now, that's not the rule, but it can happen, and that's this famous story of John Ritter. That's what happened to John Ritter, the actor from the 80s, who passed away from an aortic dissection. So essentially, when the dissection occurs, one of those layers separates from the others, and depending on how extensive that separation is, it can be mild symptoms to significant symptoms. But typically, most people who have aortic dissections complain of severe, sharp chest pain, like something's tearing inside of them. It literally is tearing. One layer separating or tearing away from the others. So kind of the picture here we have is, again, same picture as the last time, color. This really does look like plumbing, doesn't it? So this is the plumbing that comes out of the heart and supplies your body, as we talked about the previous time. And so the tear can happen anywhere in here, but there's three typical locations. One is in the ascending aorta. This is the part that's climbing up out of the heart, and if it involves your coronary blood vessels, then you can cut off the blood supply to your coronary arteries, and then you have heart attacks and all this other bad stuff happening. So ascending dissections, transverse dissections, and then descending dissections. Descending dissections, I guess I shouldn't say this, but they're probably the least dangerous so-called dissections. But if this thing dissects all the way down into the abdomen, which it can, then you can have some real problems, like the kidney arteries can be blocked. And then if you don't get to that within 6 hours, if a complete blockage to the kidney artery occurs acutely, then that kidney will die and not be able to be salvaged. Similarly, there's vital blood vessels to the intestines that need to be preserved, and then it can actually shear off a blood supply to the leg. So imagine again, if the inside lining shears off and the rest of it can continue all the way down here and block off one of the blood supplies to the leg. So the ones that we see after trauma typically occur after the subclavian artery, and that's because of there's a embryological kind of remnant left over that's tethered here, and so that shearing force from a blunt deceleration injury typically tends to tear here. Remember, this is a two-dimensional picture. The aorta is a three-dimensional structure, and it's vibrant, and it's moving constantly with each pulse. And so this doesn't really give you a clear representation of what the aorta looks like or how it acts. But anyway, those are the areas of the section, and typically the symptoms are severe chest pain or, like I said, sometimes the tearing sensation. And then if you have what we call end organ involvement, like if it cuts off the blood supply to your carotid arteries or your intestines or your kidney arteries, then you get other symptoms like carotid arteries. You can get stroke symptoms. Kidney arteries, you can get into kidney failure. Intestinal arteries is a disaster. Not a disaster. They need to be addressed quickly because that's the blood supply to the intestine. But the key is, once you get these symptoms, that you go to the emergency room quickly or transport the emergency room quickly for diagnosis. The diagnosis is made by what's called a CT angiogram, CT scan with X-ray dye, pulsed, the bolus of this contrast is given so that this whole thing can be imaged well. And once that diagnosis is made, then sometimes you need urgent or emergent surgical intervention, depending on where this dissection occurs, where it ends up, how many organs it's involving, or it can sometimes be managed conservatively. In the old days, we used to manage the ones that occurred here conservatively if they didn't cut off the blood supply to the organs. But nowadays, there's a flux, there's a change in the way these things are being handled. But nevertheless, the CT angiogram will show it. Sometimes a transesophageal echo, which I had done years ago, that's a month ago, will show this kind of stuff too. And then you get a collaboration between the heart surgeons, depending on the level of the dissection, and the peripheral vascular surgeons like myself, in terms of fixing this stuff. Sometimes we can fix these stuff with stent grafts, where we go into the groin artery and tack the dissection up, relieve the or improve the blood flow to the intestines. But sometimes you'll need replacement of what's called the ascending arch by the heart surgeons, where they actually have to replace this segment and then tack things down. There are places nowadays that are able to fix this so-called percutaneously with stents. That's not the typical way, but I think things are going to head that way, obviously. So needless to say, this is a complicated problem, but it needs to be addressed urgently or emergently. And so if you have any of these symptoms and there's a concern for aortic dissection, CT angiogram of the entire area plus or minus transesophageal echo, and then either surgery immediately or slightly delayed surgery to tack some of the stuff up if need be, especially if vital organs are involved in the dissection plane. Don't want to go too far into this because this is really complicated and evolving, but that's just the kind of a overview of aortic dissections and management. Next time we'll talk about an interesting thing. I was at the gym the other day, and a woman came up to me. She knew I was a vascular surgeon somehow, but anyway, she asked me a question about bruising in her arms and legs, and I thought that was kind of I get asked this a lot, and we should probably spend a minute talking about that stuff. Spontaneous bruising. So I'll see you guys next time.